Hi, thanks to Dr. Eli, Ms. Vitsky, and Coleman for the invitation to speak. So I hope to show you that transplant is still a necessity despite all the exciting drug regimens and responses you've heard about so far today. Basically, I'll just divide briefly initially the part to talk to response depth by conventional criteria with respect to transplant, how novel agents compare with conventional criteria, but why we need to move on to MRD, what is the role of transplant in achieving MRD, and what do we know about novel agents when combined with transplant with respect to achieving MRD. So if we temporarily put aside, you've all seen the IMWG criteria, but if we put aside the top bar and just go back to what we used to do, which was VGPR and CR, this was a meta-analysis published in 2007, which looks at all the studies that have been done, both prospective at the top as well as retrospective at the bottom, and you see that with increasing depth of response, there's a consistent pattern towards improved overall survival. And obviously the retrospective studies show the same thing. The question then would be, what about novel agents? And this is just one example of a study from the French group published in 2011, and you see this was basically VAD versus bortezomib-dex induction consolidation with DCEP followed by transplant. And on the left, you see that the PFS post-transplant was superior, obviously, if you had a deeper than VGPR. But interestingly, on the right side, you see that with bortezomib and dex, just looking at bortezomib dex alone, whether or not you had a VGPR or better, also correlated with improved outcomes. So we're seeing that even in the era of novel therapies, the quality of response does correlate with progression-free survival in this study. So you've seen many permutations of these, but what's happening now is when you have regimens, as shown towards the right part of this graph, which are having VGPR rates greater than 80–85%, what is the discriminating ability of that kind of depth of response in terms of predicting outcomes when all your induction patients are doing so well? And it's for this reason that we need to move past the current criteria. And this, you've already heard in detail this morning from Dr. Langren about MRD, and I'm not going to go through all of these, but I think this is a nice table that summarizes some of the major things that we need to think about when we pick an MRD technique, including what percentage of patients is it applicable to, is it reproducible, is it available globally, standardized, how much time does it take, cost, what's the sensitivity, do you need a fresh sample, what if the bone marrow is patchy involvement. And so when you look at the currently available techniques between the flow, PCR, next generation sequencing, and PET-CT, you have the different considerations. And I think one of the things that it's really important to remember is, and the Arkansas group in particular has been talking about this, that when we do a bone marrow aspiration, it's a limited window into the patient. And we've all had patients that have either oligosecretory disease or macrofocal disease. So what is the role of a bone marrow in that patient? So you get a negative bone marrow aspirate, but the PET or MRI still shows disease. So I think it's important, you've seen this kind of curve with depth of response, and it's important to remember that we should really be thinking about these particular techniques in patients who are radiologically negative. Putting those considerations aside, what is the role of MRD in the current era, particularly with post-transplant? Dr. Munshi just presented last month at IMW some interesting results from a meta-analysis of MRD. And they looked at the literature and retrieved 21 articles in total, including in the green are people who received any response versus in blue the people who achieved a complete response. And of these studies, when you look at the effect of MRD in the CR patients in particular, 4 studies were selected for the patients who were in CR, and comprising about 500 patients. And as you can see, the hazard ratio was 0.44, or 56% reduction in risk of progression if you were MRD negative. You do see that the Sweden study, the bar does cross 1, but it's important, that was only about 36 patients that was done with the PCR. So it's a small study and not surprising that the confidence interval is so large. But the consensus in these studies seems to point towards an improvement with progression-free survival. And that's similarly shown on this graph with MRD negative median PFS of 60 months versus MRD positive 36 months in blue. What about overall survival? Well, obviously, we now need to make sure the patient populations are comparable. And so when we focus, this is, again, what we're tasked with today, this afternoon, is what is the role in transplant patients. So these 3 studies were specifically focusing on MRD post-transplant. And again, you see that the MRD negative status reduced the hazard of death by 53%, and the hazard ratio was 0.47. And shown another way, the MRD negative did not achieve a median overall survival, whereas the MRD positive had a median overall survival of 82 months. And you could argue one of the things that always comes up with this kind of depth of response analysis correlating to outcomes is this just a surrogate for people who do better? And along those lines, is it possible that what we're just seeing is a surrogate of molecular risk? And in the 2 studies that specifically looked at both the myeloma 9 as well as the Spanish study, you can see that you actually can separate out into 3 curves. The worst group in yellow are the patients who had both high molecular risk and were MRD positive. And the best group were those who had standard FISH and MRD negative. And obviously, if you had one or the other, you were intermediate. So while there is an interplay between FISH and the depth of response, in multivariate analysis, these come out independently. So it's not enough to just look at FISH, and this is not just a surrogate for MRD. So with that information, the question now becomes, what about these novel regimens that we have, like KRD? And the Chicago group should be commended on doing some very interesting work, starting with the initial KRD study that's been published in Blood 2012, where transplant was deferred and patients got carfilzomib, lenalidomide, and dex with really unprecedented stringent complete response rates of 55% and 3-year disease control rates of 79%. But you could flip that around and say 45% didn't achieve a stringent CR, and 21% of the people still relapsed, even with stringent CRs, showing us that a stringent CR still, we haven't yet gotten to a cure. And so their question was, what is the role of transplant? Can we do better than just KRD? And in this study that was presented by Dr. Zimmerman at ASCO 2015, basically what you see is the initial KRD induction for 4 cycles, and shown below in yellow is the number of patients that have progressed through each of these different parts. So after the 4 cycles of induction, the carfilzomib dose was shown there, 20 escalating to 36 milligrams per meter squared, standard dose len and dex, followed by transplant, MEL 200, followed by 4 cycles of consolidation, followed by 9 cycles of maintenance KRD, where the carfilzomib is days 1, 2, 15, 16, followed by len maintenance. And what you see here is that the depth of response clearly improves as you go from induction to transplant to consolidation to the end of KRD. And I think it's pretty obvious that the biggest improvement in the depth of response is not occurring with induction therapy, but really post-transplant and with the consolidation added in. And I think this is a really important slide because the question that we were asked is, can you get rid of transplant in the current era? And this slide clearly demonstrates with very detailed serial follow-up in the same patient that the depth of response matters and that the depth improves with transplant and extended therapy. And specifically looking at MRD, because as we alluded to, there was a fair amount of stringent CR, but you see that not only do the stringent CRs go up from transplant to consolidation to the end of KRD from 22% up to 87%, but also the MRD negativity goes up from 60% to 100%. Again, we have to caution, this is a relatively small sample size. There's only 8 patients down at the end of that, and we clearly need larger studies. But I think this is an initial insight into the role of transplant in the current era of even highly potent regimens like KRD. So what are the unanswered questions? Because based on that information, you might think, okay, well, we're done. But I think we have yet to hear from a larger study, the Dana-Farber IFM, which is the prospective randomized study, where we'll really understand the role of transplant in this correlating with depth of response. Who needs a transplant? When is the right time? But I think given the potency of KRD, it's unlikely that we're going to get a different answer from Dana-Farber IFM, although hopefully we'll get that this year. Second question, while we looked at in multivariate analysis about the independence of MRD with respect to FISH, There's been numerous studies saying that FISH may not be the end-all and be-all, and perhaps GEP is the better way to look at molecular risk. So what is the role of MRD when you integrate GEP information? That'll be very important to understand. The next question would be, who should be tested for MRD? In other words, what is the specificity of MRD testing? Up till now, all the data I was showing you from Dr. Munchi's meta-analysis was for the patients in the lower part of the table, conventional measurable disease was negative. The question is, if you have conventional measurable disease, clearly, if it correlates with MRD presence, that's evidence of residual disease. But there is not 100%, the table is not so clean, and there are definitely patients who have measurable disease by conventional criteria, but are absent by MRD testing, which goes back to what if the bone marrow is very patchily involved and you happen to get that aspirate and get an MRD negative result. So I think the best MRD test is yet to be determined. Many feel that the molecular assays, particularly the peripheral blood, perhaps exome analysis, and in PET and MRI negative patients, might be able to overcome the limitations of a single bone marrow sample. But clearly, a lot of work needs to be done. I think the impact of this new era of immunotherapy that we're about to embark on MRD is really unknown in two ways. Is the significance of a monoclonal antibody-associated CR going to mean the same thing as a KRD negative CR? Yet to be seen. And of course, the antibodies that we give are typically IgG antibodies, and when we give these exogenous IgGs, what is the impact on serum immunofixation? And going back to the table, if we're only doing it on patients with conventional measurable disease negative, might we be missing some CRs? And efforts to overcome that include interference assays to distinguish between endogenous and exogenous protein, as well as the heavy light assay that's now been available commercially. And finally, a really unanswered question is, we're trying to move to personalized medicine. Can we use MRD not just to predict outcomes, but to eventually guide treatment intensity? Can you back off on the stringent CR MRD negative patient, and can you augment for patients who still haven't achieved that? So I will submit that we have a lot of unanswered questions, but I hope I've shown you today that with conventional criteria, we know that depth has consistently correlated with overall survival post-transplant. We have unprecedented depth of response with novel agent combinations, clearly warranting deeper measures of response. If we use MRD to measure response depth, even stringent CRs are still relapsing with regimens like the highly active KRD. MRD negativity, as shown by Dr. Munchi's meta-analysis post-transplant, is still correlating with both PFS and OS. And finally, perhaps most compelling, the KRD data from Chicago Group clearly shows that the biggest improvement in achieving MRD negative state was really after transplant and consolidation, not just with KRD induction therapy. So I would submit that the data as it stands now, with our current therapy and current modalities of testing, transplant is still a necessity to achieve a stringent complete response and MRD negativity. Thank you.